Hello, everybody. I'm Mel Hauser. I use she, they pronouns, and I am the executive director of All Brains Belong. Welcome to Brain Club. I'm so glad you're all here. Tonight, we'll be continuing our August theme of learning and unlearning. Tonight, we'll be talking about unlearning in healthcare. And of course, there is so much unlearning that is required. By way of introduction, if you're new to Brain Club, this is our public education program for purposes of providing education and modeling neuro-inclusive community culture. The idea is to promote new ways of thinking and being, and then go out into the world and carry that out elsewhere to contribute to systems change. What we are hoping is that this is a place where everyone, whether it's your first time or you've been coming for years, a place to feel safe, a place to experience how neuro-inclusive culture can be and how culture can be different, and where we learn and unlearn together each week. And although All Brains Belong has a variety of different types of programs, this one is not for medical or mental health advice. It's also not a support group. This one is for education purposes only. So we invite you to explore today's big picture, and you can certainly share ideas or reflections related to that topic. And we always mention this, intentionally, especially when we're talking about healthcare, it can get a little bit dicey in terms of that distinction between education and like support group, and especially because we know that the healthcare system is so broken. We know it's so broken, and so many people have had really bad experiences related to healthcare. But this is a place. Tonight we're going to be focusing on moving forward and providing education about ways of moving forward. All paths to participation are welcome here. You can have your video on or off. Even if it's on, we don't expect anything of you. We certainly do not need you to sit still or look at the camera or any of those other neuronormative constructs. So please feel free to walk or move or fidget or stim or eat or take breaks or whatever else needs doing. Observation is also a valid form of participation. And it's really important to us that we create space for everyone to participate in their own way, whether that be by mouth words or in the chat. So giving lots of space for processing and space for people to enter into the conversation if they would like to. Because we all have different brains and we all have different access needs. Access needs being anything that is required for full and meaningful participation. Everyone with all types of brains has access needs. It's just that depending on what environment and culture and, all of that, you may be more or less likely to have your access needs met. All different types of access needs. So some of the ones we like to bring up front. First is about closed captioning. It is enabled. You just have to toggle it on if you'd like to use it. So depending on your version of Zoom, you might see the live transcript closed captioning icon. If not, look for the more ... and choose show subtitles. You can also do the same and choose hide subtitles if you want to turn them off. And that's my visual support to make sure the chat is open so I can see it if anybody's using it. Hello, everybody. All right. So some of tonight's Brain Club will be a pre-recorded panel. And so while that video is playing, you are welcome to ask questions or comments in the chat to validate other people's comments or share how something you've heard has impacted you, or ask questions from our staff. We just ask that if you are going to use the chat, couple of asks. One is that you use the big box, just the main chat box, as opposed to the replies or the threads, because that makes the chat bounce, and our facilitators' access needs are such that we are unable to facilitate when the chat is bouncing. We also ask that, again, because we are focusing on moving forward, we ask that you, try as best you can to be focusing on moving forward as opposed to, sharing past bad experiences or venting about the topic. Before we begin, I also want to say that this weekend is our third annual Community Health Education Fair. The two ways to participate. One is in person if you're local on the Vermont State House lawn, but if you're not, or are looking for a virtual participation, there is a live stream courtesy of Orca Media. And so in person will be a resource fair with about 55 community partners sharing resources and activities for all ages. And both in person and live stream will be community storytelling, which is basically like Brain Club, but shorter. Like there'll be 5 short segments, Brain Club style, of community members sharing their lived expertise with the audience, and there'll be a concert. So we'd love for you to participate in whatever way works for you. And at that link that Sarah just posted, that's where the link to the live stream is as well. All right, so as I said, continuing our conversation about learning and unlearning. You know, what we talk about a lot here at Brain Club, right, is that one size fits all does not work for all. And since so many systems in society are offered in a one size fits all way, people whose brains work differently than those default ways often struggle to access critical resources. And we talk about this all the time at Brain Club. So healthcare is, of course, one of these major critical resources that is so hard to access for so many people. And we know that neurodivergent people have higher rates of chronic medical conditions, and in particular, higher rates of medical conditions that are poorly understood by the healthcare system. They're not part of medical education, and that the healthcare system really gets in the way of clinicians being able to manage appropriately. And why that is because many autistic and ADHD people suffer from a constellation of intertwined medical conditions. They're intertwined, they're all related. And the management of some parts of that cluster often make the other parts worse. And so because the healthcare system often forces clinicians to fragment body parts, you know, we only have 10, 15 minutes, we can only address one body part today. It really gets in the way of clinicians being able to address the whole, which is what, of course, patients need. So if you want to learn more about that constellation of intertwined medical problems, as including resources for both patients and clinicians about how to get your needs met about these things, Sarah's posted the link in the chat for this Everything is Connected to Everything, which launched a year ago last week and has been accessed by more than 15,000 people, which we're really excited about. If you want still more resources, this is our resource that launched a couple of weeks ago, our new Neuro-Inclusive Healthcare Education Hub that has webinars and blog posts and podcast interviews and plain language summaries and a whole bunch of other things if you want to dive deeper into those topics than we're going to be able to do today. Today, we are going to take on the challenge of bridging the double empathy problem. This is a term that we talk a lot about at Brain Club, a term coined by Dr. Damian Milton, who was an autistic social scientist in the UK, who found in research that there is communication breakdown when two people have a mismatch of the way they see the world, a mismatch of their communication style. It's not that there's like one normal type of communication skills and then there's, you know, these people over here who don't have them. It's in both directions, difficulty with perspective taking. And oh, wow, is that true between doctors and patients? It's hard to communicate in healthcare. The healthcare system is broken. And even when there is, someone has access to communicate within the span of the 10 to 15 minute appointment, using the just so language to get attention to their medical problems. I mean, it's chaos. So one of the components of our Everything's Connected to Everything resource is a letter that if you think that maybe this constellation applies to you, you can print off this letter, bring it to your next primary care appointment, just hand it over. It works best when not accompanied by a lot of extra information. It's just, I learned about this project. Can you look at this with me today? That's it. And we have found that often that is well received, and it's a letter that's written in language that primary care doctors are used to reading. It was vetted by 20 primary care doctors who work in the traditional mainstream healthcare system. I was like, yeah, if somebody gave me that letter, I would read it. And what it does is it directs the clinician to resources that are written in such a way that they are used to receiving. And so it's a tool that is intended to take the burden off of patients of like having to like contort yourself to like fit in the just so way. Let the letter do the work for you. So before I introduce our panelists and our panel, I just want to name one more thing. We know that the healthcare system is broken. And we cover healthcare at Brain Club. And often healthcare professionals join us for Brain Club and they watch the recording and et cetera, et cetera. It's like an opportunity to be doing some education about the world we want to see in healthcare. So we really want to just focus on creating a safe and inviting space for everyone to learn, where we're, trying to share that practical information for people who can use it. So we just will. So with that being said, we're going to watch an interview, a pre-recorded set of interviews with 3 primary care physicians who practice in mainstream healthcare: Dr. Laura Bujol, Dr. Laura Black, and Dr. Tim Lishnak. These are physicians who did not know about this constellation of intertwined medical problems, and they did not know about the tools, and they learned about them, and they found the resources. Well, I'll let you hear from them about how they found the resources and how their practice has changed. So let me stop this. Let me switch to this. And this will run about 27 minutes and 49 seconds. And so during that time, you are welcome to use the chat as we watch. Here we go. I'm supposed to make my volume louder because I never remember to do that. Okay. One of the things that's going to be that is so powerful. Thank you, everybody, for supporting my executive functioning. Yeah, I never clicked the share sound button. That's like a separate thing in Zoom, and I never remember to click it. I'm sorry. Reshare with the sound. Thank you for the feedback. Let's try again. I think, one of the things that's going to be that is so powerful about this project, and both, your role as a reviewer and your role now, is I think it's about application in a traditional practice. Like I can go out there and be like, I have a practice with autistic and ADHD people, and this is the medical problems they have. But it's like, all right, well, that's nice. I don't have that practice. I think it's important to learn from how is this resource actually, like playing out in like the regular world, like in the traditional healthcare system. Yes. Because that's where the mass impact is. That's where most of the patients are. I'm curious, was this a pattern that you were already seeing in your patients?
I think there was somewhat of a pattern, maybe, but I think I notice it more now.
So when we first connected about this constellation of medical conditions, I kind of remembered you like be like, yeah, I kind of anyway. So like, was that a pattern that you think you had been seeing?
In hindsight, there's some people that come to mind. There's some patients that come to mind, and I'm like, oh my God, could that be for them too? And I don't know if I could immediately connect it to all the things, and this patient of mine, are they autistic too, versus does it explain why they're not getting better on certain treatments? And I think pain was a big thing. Pain is a big barrier to patients that I see, whether it's treatment of obesity, diabetes, or just making any change to their lifestyle, but I'm in too much pain to do that.
Was this pattern, was this something you were already seeing?
I'd have to say personally, yes. I think all of us in medicine and in primary care, we tend to attract a certain audience at times, and perhaps in how I go about things, my audience has a certain number of folks for which there are a lot of interconnected and intertwined challenges, and so I was already, have been working with these patients for many years now, and learning from them, working with them and learning from them. And so this the presentation certainly validated everything that I've and my patients have been experiencing.
There's just so many people who don't know about this. We have patients who they've been struggling for decades. And the pattern wasn't matched, and I blame the healthcare system for that, because of the thwarting clinicians from being able to take in all this, and take in anything new.
Yeah.
What do you think of that?
I mean, what I tell the residents is, like, sometimes you will feel like you're kind of in a checkbox world, and we need to remember to look outside of the checkbox world and look at the person sitting in front of you and get them what they need.
How do I get the care people need when it's so obvious and it's like low-hanging fruit, but insurance won't cover it, or insurance covers it and it's not available? It's like, if you want to help somebody, how about we start with the chronic conditions, or prevention of the chronic conditions, or prevention of the exacerbators of the chronic conditions, but instead we're focused on the treatments. And you have to be this sick to get this treatment, but it makes no sense to wait until you get that sick.
System, right? The system thwarts everybody.
The healthcare system is so complex, even the people in it have trouble understanding it.
So like, you're seeing this and you're recognizing that everything's connected. And yet, a lot of these patients, they've seen lots of clinicians.
Yeah.
What do you think gets in the way of professionals not making those connections?
I think it's the dynamic between the provider and the patient. So the few patients that come to mind, I think there's something behavioral or mood related. And unfortunately, I think the patient is angry. What I've experienced as a barrier is a patient is angry and frustrated and fed up because they've been either obviously discriminated against, told off, told that they're not being taken seriously, and so they develop this defense layer. So, and that, I think, in some cases can also be some of the pathology. Like, I think fibromyalgia is another good example as a comorbid condition here. And then there's this overlap of some psychiatric diagnoses too. Severe depression, bipolar disorder, trauma. So I think that's been really hard, because then it's hard to get in and really connect with a person. So behavioral dynamic, interpersonal dynamic, I think sometimes they're perceived as moody or dramatic, unfortunately. And a lot of these patients are women, not all. And this is where I would love to learn from you, because I don't think I fully understand, and maybe I don't see the same population fully represented as you do too. Some people are in hiding, some people do not come to the doctor. But usually they're angry, frustrated, discriminated against, fed up.
The system is so broken. Why don't people get faxes? I have no idea. But, little things like that, because, to be honest, I feel like I think it goes back to what you're saying, just like all the things you have to keep track of, and then you're not feeling well, and then you have to go back and forth, and then you have to go through the phone tree, and I don't like the phone trees. It's just, it doesn't work. And
a lot of patients who have this constellation of intertwined conditions, they have a lot of negative healthcare experiences. They feel that they have been invalidated, dismissed, that people didn't, they didn't get it, they didn't hear them. What do you think of that?
That's been a journey of discovery for myself in that I think as a physician, we hold ourselves to, I need to have the answer. And if I don't have the answer, that's going to be unacceptable to the patient. And working with these folks, that's not their expectation. They just want someone that will listen to them and work with them.
I think about neurodivergent nervous systems, and all neurodivergent folks are a very heterogeneous group, of course, but when I think about like even sensory processing, like the sensory systems that are either taking in more information than other people or less information than other people, an energy system, I think the neuroception system, the threat detection system, there are a lot of people who are extra sensitive to threat. And it's like acquired trauma physiology, that hypervigilance, that like looking. So if I'm someone who has hypersensitive neuroception and I enter a healthcare encounter, there's going to be something that someone's going to say or do that is I'm more likely to experience as threat because of these cues from the environment, my lived experience, the vibe.
I think that underscores the importance of how we communicate. And you just look at the words on a page and you could communicate those in so many different ways, whereas the content's the same, but the way it's conveyed and the way it's received is so different. And we, I not only I'm seeing patients, but I get to work in a training environment and spend a lot of time talking to our doctors that are training in family medicine of the importance of how they communicate and how they convey those messages. You're embedded in that individual's care, and they're going to partner with you. And that, yes, those tests were, we use the term negative a lot. The test came back negative. But yet that doesn't mean that there's not something going on. It's just that we haven't found it, or that the test won't show it. And trying to kind of communicate that is so important, especially when dealing with questions to which we don't have answers just yet.
I think that energetically and cognitively, like that openness, like that constant, like that the metacognitive aspects of medical practice, where you're like thinking about how you're thinking and learning and moving through the world, and like, oh yeah, there's this thing that now I'm being presented with, and it wasn't like part of my thing, but I'm open to new things coming into it. Not everybody can do that, right? Metacognition and this like cognitive flexibility piece is a higher order brain function. And the system thwarts everybody, like the healthcare system. Like it doesn't just thwart patients, it thwarts us, like it thwarts clinicians. We're just like treading water, trying to survive a lot of the time. We don't actually often have access to those higher level functions.
And then there's the time barrier. The very patients I'm thinking about, I ask for extra time and it goes so fast and it's not enough. And I even go over and it's still not enough.
You're bringing up the barriers that happen, like the barriers to access while they're there. So yeah. But there's so many barriers that even prevent them from getting there. Yeah. So you must pick up the phone to become a new, to make an appointment. The executive functioning of like all those pieces too. Yes. And you mentioned trauma, all these people with healthcare trauma. It's like, well, I made the appointment, but I'm going to cancel it last minute because like my limbic system tells me that it's not safe to come back to this place.
The patients I do know who have a diagnosis of an autistic disorder or of some sort, or something else going on with a neurodivergent diagnosis, because I think that's relevant to what we're talking about here, or people who aren't diagnosed or people who don't have the diagnosis. But I can think of a few people who probably either avoid care or even are discharged because of no-shows and things like that. And it's terrible. It shouldn't be.
I think systemic ableism is like so embedded in medical training and practice. All the people that when they don't come to appointments, it's like, oh, well, they no-show, they don't care, they're not engaged in their health care. But it's like, okay, whoa, it's maybe because of their disability that they don't know they have. You don't know they have, and they don't know they have.
The system is created a certain way. If you don't like it, then you can look for another job. I do know I have friends at other places that I won't name that are, yeah, as you described. They
Right,
don't, you don't have time to think it almost seems they don't really want you to. You just need to do these things this many times a day and move on to the next thing. And,
You're a
no,
cog.
yeah. But those docs aren't, you can see them not being happy. That's not what we went to school for.
These patients describe that in all of their years of failed healthcare interactions, they felt that they were not believed. And so they come in and they have the stories of, they were invalidated and dismissed and shut down. They were told, go lose weight. They were this, they were that, like just all of that. But these patients, especially these late identified neurodivergent adults, they have been invalidated and dismissed and shamed by so many people in their lives. And so they come in and doctor says, well, your tests are normal. And now it's this trauma response, which I think is a unique barrier to healthcare access and engagement that I certainly didn't get taught that in medical school. What do people say that when they, after they've like seen that the map is like bigger than even the patterns, you can't unsee it. So has anything shifted at all about, you'd seen it already, but now that it's like, oh, this is a thing, has that impacted what, anything?
Interesting in some of the short answer is yes. The long answer is acknowledging, how things are interwoven. It's taking a look at our interventions, whether that's a prescription, a supplement, a modality that we're using, and recognizing not only the potential for good, for benefit, but also having to be cautious about, can this be harmful?
Like the relative contraindications. Like I didn't realize that in this particular subpopulation, these things that are evidence-based practice, like propranolol for POTS or something, I didn't realize that in this population, that is going to make this person worse.
Yes.
And
well, that's like muscle relaxers. I remember reading about muscle relaxers. I was like, reading it makes so much sense, but I have to admit, I've reflected a lot on who I've prescribed muscle relaxers to and who should or should not get them.
yes. And it's really hard. Like, we trained in an era where it's like, well, don't prescribe opioids. And it's like, well, what do? You like muscle relaxant. It's like, and without like necessarily even recognizing like, what is pain? Really to actually think about, for some people, pain is their joints going out of alignment. It's mechanical. Yes. For some people, it's like they're cutting off their blood flow. Or like, people who, on surface appear to, be healthy, but they really have like really bad small fiber neuropathy. Just like all these things that I don't know, they weren't on my radar. They weren't on my radar until I experienced them personally. This is what's going on for a lot of people. So muscle relaxant, you just made them worse.
Yes, because I think I think a lot of our treatments serve, again, we have this huge spectrum of human, and it kind of serves this middle. And if you are in a system, which I am not, where you need to see someone every 15 minutes, you don't have time to think about all those other people on both sides. And that's, I think, where people don't get better, or they don't trust their doctor because they're not listening. But I'm not giving excuses to doctors, but when you're in a system that sees someone every 15 minutes, it's just a challenge. I did go through the guide. I haven't gone through it recently, but I found a lot of the things in the guide were things that aren't complicated is what they're not complicated. And I think that's kind of what blew my mind. So
I don't know if you've, looked at the, the clinician resource guide, and if there's anything in there that, if you've used it, it's totally fine if not, but if you used it, I'd love to hear about that.
Yes, yes. So answer, I guess, yes to all of those questions. Have looked through it, and using it as a reference when I'm meeting with a patient, and that's in the back of my mind, going through things that we're discussing as far as symptoms they may be experiencing or signs they may exhibit. And that sense of, okay, what have we done, what have we tried, what else could we recommend? More recently, it was working with someone who is in experiences a lot of chronic pain as a result of hypermobility, and exploring low dose naltrexone.
Since talking to you, like especially like things like hypermobility, EDS, how do we manage that? I've reached out to our children's hospital, physical therapy, our adult, and luckily our physical therapy office right next to our office will take adolescents and help with joint stabilizing. And they gave me the name of the person who specializes in that. So it's been very helpful.
Looking at some of the medications that we've been using, or even supplements, and trying to fine tune those for minimizing the side effects and maximizing the beneficial effects. And that's been an ongoing navigation process.
I love that you said that, like back in the day when we first started working on this, the idea of turning this pattern and stuff we were seeing into like a usable resource, it was really first and foremost about the latter. It was the idea of, wow, there are some standard medical interventions, medicines, supplements that actually make some of these other parts of the constellation worse. And holy cow, I don't know, like I didn't know that. I don't know if people know this. Like, so it was really about identifying those relative harms within the constellation.
And I think relative's a very good choice of word. I often have this discussion with folks that we're always looking at what are the risks and benefits of these interventions, and when there's the thought that the risk may be minimal, that doesn't mean zero, but that the potential benefit may be greater. I push that into the reasonable status. And again, getting back to the trying things, it's working and saying, okay, let's try this. We'll talk again next week, and then we'll find out if it was helpful or harmful or somewhere in between, and then let's look on the other part. So it's very much a team effort, and now it's becoming increasingly a community effort when there are additional resources for all of us to share victories and suggestions, and again, kind of try things with that ultimate goal of improving the situation.
Now that you have this framework, like you're a systems thinking pattern matcher, like that's how your brain works. So like now you have this it's not new, but like you have this thing that now you're matching, like as you go through the world.
Like even I have like this now, the hypermobility chart.
Yeah.
So I'm still learning, but I feel like I've come a long way since we've talked, and hopefully I'll keep going.
Yeah, we certainly have to acknowledge that we don't have all the answers, but we want to work collaboratively on addressing things that we're able to address.
Absolutely. Anything I didn't ask you about that you want to mention?
Oh, we've covered a lot of ground. I just again kind of reiterate that partnership that's so important with patients, and the navigating the journey together. We learn from our patients. A lot of the tools and techniques that I might be applying to folks, I'm getting them from others, and looking and listening and saying, okay, yes, you were on a support group, and this was the topic of conversation. Well, let's look at this a little bit more scientifically, and let's explore this treatment and find out if it might be a safe and effective modality that we can use. And a lot of times the answer is yes, and we decide to go forward and try something along those lines. But in the absence of those groups and those forums, we might not be moving forward.
I love that you said that, because I didn't tell you this part, but so Brain Club, so this program, this interviews with 3 or 4 primary care physicians talking about this project. This is part of where this is going to go. We have a weekly community education program called Brain Club, and every month has a big overarching theme, and then there's subtopics each week. So the theme for March is systems change from the ground up. And what you just said is exactly why this topic is in March Brain Club. It's next week's Brain Club. Because it's the idea, like we learned this from our patients. This really is this village here of learning and healing together. And it just so happens that there was evidence to support each piece of what the people brought us. But we wouldn't have been looking for it if they didn't bring it. And so really just co-creating, we had, more than 100 people in focus groups sharing what worked and what didn't work. And that's how we learned about the relative contraindications, relative harms, or like things that side effects we didn't know about. Anything else you'd like to say or share?
How do you talk to someone about all the things, and how do you even say that? It's so foreign to me. How do you kind of open up that door with a patient?
It's like this self-selected group of people whose needs were not met by the traditional healthcare system. They are, so it's and certainly not a homogenous group of people by any means, but amongst that group whose needs were not met, they were more likely to be autistic and or ADHD, and they were more likely to have this constellation. So a new patient comes in, and like I've done on my like new patient intake forms, I screen for all the things for all my new patients, and I'll send you what I use. It's very much like a simplified version of what we have up on our All the Things Project website. But so I'll say, I noticed that you had X, Y, Z, A, B, C. Did you know that there's actually a grouping or a cluster of intertwined medical conditions? And I usually, whether they're, if they're in person, I'm like, turning my laptop, if they're virtual, I'm sure screen, and I show them a visual support. I think visual supports to sort of like anchor what you're talking about. I think most brains benefit from visual supports, whether or not they are like dependent on visual supports or not to process
agreed.
something.
Totally.
It's different, right?
Yeah.
So the visual support I use, which is the one that's in the All the Things guide, is that, I don't know if you've seen like the rainbow braid.
Yeah.
That has all the different systems. Yeah. So the majority of patients who come to All Brains Belong, they struggle with a grouping of medical conditions that involves something in the connective tissue bucket, something in the GI bucket, something in the sleep bucket, something in the, pain bucket. And like you see them, they're like, the mouth drops and their eyes are wide, and you're like, and I'm like, oh, do you think that applies to you? Like, I don't know, like, they're like, that's me. Like 1,000% of the time, that's what they say. And I say, well, I think the healthcare system often interferes with clinicians having the opportunity to address multiple problems at the same time. But really what happens is that when we fragment out these different parts of this cluster, we miss the fact that there's like internal conflicting needs where some standard parts of this cluster make the other parts worse. And so like zooming way out, turns out that if we approach this through a lens of a big picture, we find the things that make your thing better without making the other parts of your cluster worse. Like in my practice, we do a lot of group medical appointments. We do a lot of like group learning and a lot of like visual supports and education and stuff. But I think like in a traditional practice, I might just like send them to the All the Things site. Hey, okay, check this out, and next time we can talk more about it, and let me know if any of this resonates with you, because there's all those patient tools on that site.
Thanks.
Yeah.
That's simple enough. I like it.
One of the things I think we still struggle with is that patients, I think, have often internalized the healthcare system narrative of like, well, what's this? You know, what's my hypermobility contributing versus like, what's my fibromyalgia, or like, what's my mast cell dysfunction, or it's like, whoa, what would it look like to zoom out and say, like, we don't have to fragment your body parts. We could support your neuroimmune health in this way. Do you have any thoughts on that?
Well, I think that goes along the line of the specialization in many ways. And okay, you've got this body part, so you see this person. You've got that body part, and you see that person. And those people aren't always talking to each other, even though your body is. You
Is
know?
there anything that you and the patients that you work with would like to give to doctors like me who are probably needing to learn more about, what is there anything universally helpful that we can do to break down a barrier and invite change?
So I stopped it right there. I stopped the whole video there, because I think that is a great segue into a conversation here, right? So if this is about bridging the double empathy problem, where here we have a mainstream physician asking, what do people wish I knew? Like, that is an opportunity for bridging that gap. I think that because we've all had different experiences in the healthcare system, including like really downright often traumatic experiences in the healthcare system, sometimes it's really difficult to zoom out and to, think about that. Like sometimes when people have difficult experiences, it's like the individual in the room that is like seen as the villain of that story. And the healthcare system is the villain that is thwarting everyone. And I would love to see how that concept is landing on folks. Like, maybe even to say, is there anything you've heard that surprised you about the physician perspective?
I think just having physicians being willing to say, I don't know the answer to that, and let's learn more. And understanding that, like, when running a test, there might not be a definitive answer that comes back, and being willing to keep digging for more and trusting the patient to know themselves and know their own body and know that something's not right. So I thought that was beautiful. I think that builds so much trust, like the idea of being able to say, I don't know, but let's look at this and learn more.
I love that. Thank you, Sarah. There's some comments in the chat, echoing that about, when people say they don't know, when people are wanting to learn more and still recognizing they're not knowing it all, like that does cue safety. And I think reminds me of the comment that Dr. Lishnak had in the beginning around, I thought it was that patients want me to have an answer, but really they want someone to listen and partner with them. And yes. There's some comments in the chat just around fragmentation and specialization. I think that, as I was doing these interviews, like I was trying to bridge the double empathy problem too, and speaking in a language that, I thought would kind of hit the frame of reference for primary care physicians. And I think that primary care physicians are, most likely to be oriented around integrating all the body parts. That is how we're trained, and that is, something that for many people is part of their professional identity. And so I knew that was going to be like a hot button issue that our interviewees would tap into around, like, yeah. So, specialization, fragmentation, no, that's not good for people. Like, so I think it's all balance. It's about communication. It's about, perspective taking. It's about zooming out to recognize that everything really is connected to everything. I think that any professional is capable of making those connections. It's just that when you have a healthcare system that is thwarting everyone, clinicians and patients alike, all day long, it's very difficult to have access or capacity to do that kind of thinking. There is reminding us of a brain club. I didn't know how to pull it up when I was in share screen mode, but I'll pull it up now. Brain Club 2024. This was a brain club we did in June. The best way to support my health is to believe me. This was an interview with researchers from UVM sharing their experiences. There we go. The chat links in the chat around a qualitative study of autistic adults describing their narratives of their bad healthcare experiences. It's really powerful. Rise referencing the yes and improv technique. Yeah, yes, the results were normal, and there are other things to explore. I love that. Thanks, Mariah. Sierra shared, I often feel like a large part of my job as a primary care clinician is being an interpreter in a lot of ways, right? And Sierra, can you say more about that?
Yeah, I think I started thinking about this when I was learning more about the difference between interpretation and translation, and that with interpretation, you're trying to really kind of convey the meaning of things. And I think that as a primary care provider, often I'm doing interpretation of, okay, this is the story that somebody's telling me. How do we kind of repackage this and formulate it in a way that another healthcare provider, somebody in the ER or a specialist is going to listen to and pay attention to the things that I'm picking up. And so being that in between in some ways, but being that interpreter of taking a bunch of information, doing the same thing, taking a bunch of information from a specialist and repackaging it, trying to figure out, okay, how do we actually make this work, or how do we actually, take this for the next step and actually make a treatment plan or something like that.
Oh, absolutely. Right. And like how often are we we're writing scripts for how we know that it's much like the letter in the everything's connected to everything resource. We are often creating those scripts for people to be able to show up and have access to the language that is most likely to result in the strategic purpose of that appointment. And it's really hard, right? So, and this came up in I think it was with Dr. Black, the idea that there's barriers during the appointment, but all the barriers that lead up to that appointment that are so hard. So, and I think that past healthcare appointments are a barrier to access because of the trauma response of, this is going to be yet another appointment where I am invalidated and dismissed and not heard. Thank you, Mariah. Mariah says, I want to acknowledge the job primary care physicians is a monumental task that's virtually impossible to accomplish in the face of a broken healthcare system. Yeah, thanks for naming that, right? Because it's, and I think to Liz's point about, payment reform and all of this, where the healthcare system really is, it's not sustainable. And we found, for example, that, we really needed to break free of the constraints of the healthcare system to be able to practice in the ways that we wanted to, and certainly using existing healthcare system structures, participating in most of the major health insurance payers and all of that from an accessibility standpoint, and to have autonomy and agency over our schedule and how we want to do things is really important. Sierra.
I think on that note of like working in a broken system is it creates the opportunity for the patient and provider relationship to be one of like working together against the system. And I think that can create a really great relationship or a really great opportunity with patient provider of like, okay, these are the limitations of the system that we're in. What can we actually do in there? What can we do to problem solve? What are the ways we can actually make differences? And so being able to kind of like go at that as a team and as a team knowing the limitations and still figuring out how do we still move forward.
Right. Like that's that whole difference between, top down systems change versus bottom up. Like, what can you do right now with your community? Thanks, Molly. Yeah, I think that, moving beyond the one size fits all approach, it's very, the healthcare system is about efficiency. It's about, how do we, it's when we talk about efficiency, and of course that's seeped in all of, the broken systems of all the other dysfunction, the ableism, the capitalism, like all of that stuff is all enmeshed in that. But efficiency is the opposite of slowing down and customizing. And it's that customization that really is patient-centered. Yeah. Naomi. And speaking of, one size fits all, not working for all, that really is what the Community Health Education Fair is about. It's about, it's an event that is modeling multiple different ways of participating. David.
Yeah, how much of a part of the problem is background issue, and the problem is, at least in this place like Vermont, there are probably half as many doctors as there need to be to serve the need of people for doctors. I mean, I've had to go to New Hampshire for gastro and urology. I've had to go to Rutland for orthopedics. My dermatologist I have here in town, I asked the last time I saw him how long it would take for somebody new coming in to get an appointment with him, and he's probably about a year. My GP no longer takes new patients, and squeezing everything into 15 minutes is ridiculous, of course, just as a, but if everybody had half an hour, does that mean we'd be waiting for 2 years rather than a year for appointments? I mean, there's something just fundamentally askew in this whole thing. It's hard to know how you could do some of this more thoughtful, sort of railing your way through an appointment just with somebody to find out what's really going on and and hearing. If there's this pressure on the resources.
Absolutely. Absolutely all of that. And I think that, what is also true is that when there are practices that continue to take on new patients, but your current patients now have to wait 3 months or longer to get an appointment, like they're already established and they can't get care, that's chaos. Right. And so the decision to close a practice to new patients is often based in needing to meet the needs of your current patients. And you're absolutely right. There are more people with more needs. And there are people who are being driven out of healthcare. So one of the reasons that there's a supply problem in clinicians is because it's so freaking hard to work in the system, because the system tortures you and makes you see, 25, 30 patients or more in a day. That's a great recipe. And I think that there's literature coming out that neurodivergent physicians are being, more likely to be thwarted, more likely to not have your access needs met, and more likely to quit and be driven out of healthcare. Yeah, I appreciate all the comments in the chat. Orient us around. I know that the healthcare system is really, really broken, and when your needs are not being met, it's only natural to try to solve individual problems. But I do just want to orient us that Brain Club really is about talking about systems level problems and solving systems level situations, not individual situations. Yeah. Naomi, I absolutely agree that, one size fits all being addressed in medical systems and medical education is really important. Yeah. Naomi, I'm happy to call on you, but we have 1 minute, and I just want to keep our conversation oriented around systems and not individualized situations. Is that okay?
Yeah, I just want to say, I hope a recording is going out for this. And secondly, I'm waiting to hear from this social worker at Dana-Farber who started the Neurodiversity Initiative between neurodiversity and cancer. And she's applying for some major funding. And if it goes through, I welcome people from this group to do some participatory action research visioning for that research.
Yeah. So Naomi, we don't recruit for research here at Brain Club, but I think that spreading the word on social media is I think there'll be tons of people lining up to be involved in research like that. Okay, so thank you, everybody. Thank you. So we'll next week we will be having our monthly book chat. We will be revisiting two different books that we've visited here at Brain Club before. We'll be looking at I'm Not Broken by Eric Garcia and The Rainbow Brain by Sandra Menon. So we look forward to seeing you next week. Have a good week, everybody. And if anybody's around on Saturday, we'd love to see you at the Community Health Education Fair, either at the State House lawn or on live stream. Bye.